Hi guys, welcome to the practice. I think we'll never see the classroom this full again. Big shout out to Firth for doing a quick Q&A, really for the first year fellows. You know, I think every shop, every hospital does things very differently, as do we. Everyone has their own interpretation of the evidence. Everything that we do here, 90% of what we do here is evidence-based, and then a lot of opinions. You know, I tried to go through and take a lot of questions that I think are relevant to you guys. I don't think we'll be able to get through, you know, all of them in the next 45 minutes, but we'll try. So if you guys don't know Firth, which you all should, just a quick little info. I completely got himself the website. Firth joined INSPRA in 2017. He graduated from PCOM in 2010.
No, I graduated from PCP.
PCP in 2010, has over 10 years of precepting experience. If you guys don't know, you know how he runs rounds. Has board certifications in critical care and pharmacotherapy. Society of member of SCCM. Has publications in CHEST, ATS. Obviously, a big part of what we did during COVID. He's been awarded the Heroes Award for his outstanding commitment and contributions to patient care, leading to early life-saving therapies. He's a member of the critical care committee here. Done a lot of cool stuff with that. And then, you know, most importantly for us, he's a core member of our faculty as part of our fellowship program. And yes, you can absolutely call him any time of the day and night, even when he's on vacation. Yes. As we all have. All right, so you know, you guys can stop us at any time and ask questions. I'll be presenting some clinical vignettes of common things that you're going to be seeing, and then we'll kind of go from there. So the first one, and we'll go by system. Once again, I do not think we're going to get through all these systems. I think we'll probably make it at most to GI, maybe renal, because that's how far I made some slides. All right, so first one, you guys all recognize this patient, right? This is the patient that you're getting a call for persistent agitation. They're just having major withdrawals. They've gotten, you know, hundreds and hundreds of doses of benzos and, well, not hundreds, maybe a few doses of benzos. And they're still pretty, you know, their CWAR score is like 15, right? And you get a call for initiating phenobarb. And so one of the things that we consider here is that phenobarb is going to be ICU for a few reasons. So Firth, what are your thoughts on phenobarb and what should we know about using phenobarb?
So anyone that's worked with me knows that I love phenobarb. And to be honest, I was a huge advocate against phenobarb when I first started practicing in the ICU. You know, you're trained in school that phenobarb is an old medication, it has a long half-life, we should be using benzodiazepines and kind of titrating these patients off of medications. But I've really become a huge advocate of phenobarb for many reasons. One being because, as I mentioned, it has a very long half-life. So if I load a patient appropriately with phenobarb, I do not have to taper any medications. The medication tapers itself. Does anybody know the half-life of phenobarb? 50 hours. All right. So it takes 5.5 half-lives to clear a drug. So if I appropriately load this patient with phenobarb, we're going to talk about loading versus not loading and how we dose it.
It's 2 now. Instead of 1. It's 2.
Both of them? Can they still hear me?
Yeah.
Okay. Phenobarb is a very good drug in helping get someone through their alcohol withdrawal, right? So as Uday mentioned, you need to, what? Is that me echoing?
I was checking.
Okay. So as Uday mentioned, you know, you're going to get that call usually from the ER. They've given them some benzodiazepines. They're going to tell you they usually gave a lot of benzodiazepines. Usually they haven't, all right? Most of the time they're going to say they give 4 or 6 milligrams of Ativan or Versed. Traditionally, these patients probably need at least 10 to 12 to see an effect, but it's fine. I prefer them to give less benzos before we decide to initiate phenobarbital. All right. So then the big question becomes, how do we use our phenobarbital? All right. So Ed and I, we kind of talked about this last week, but I have kind of a approach to how I tailor my phenobarb regimen. So the first thing I'm going to ask you, if you call me and ask about using phenobarb, is your patient symptomatic or asymptomatic? And you're like, Firth, I'm calling you to use phenobarb because the patient has symptoms of alcohol withdrawal. So let's differentiate. Symptomatic to me is the patient is either actively seizing from alcohol withdrawal or has DTs, okay? That's what I consider symptomatic when I'm using mifenabar, right? Asymptomatic to me is your standard withdrawal symptoms, tremulous, tachycardic, a little bit of hallucinations, not acting right, things like that, right? Which is still perfectly fine to use mifenabar, right? Oh, I can write now?
Yeah.
All right.
And one thing to not be fooled by is, does anyone know what the most common type of hallucination is in acute alcohol withdrawal? It's tactile. So, this is one of the types of hallucinations we don't usually think of. You expect them to see, pink elephants and things like that.
All right, so we've made the decision we're going to use phenobarbital. All right, the one thing that we're going to do once we've made this decision is we are not going back to benzodiazepines. That's when you get in trouble. When you mix the groups together, your patient will end up intubated. All right, so make a decision and stick with that path. So we've decided we're going to use phenobarbital.
And what do you do if they previously were on the SIBO protocol and they got like Ativan for 2 days straight? Like,
If you've made the decision you're switching over and you bring them to the ICU, they're going to be a close airway watch anyway.
Okay.
But this is what we're going to do, and that's what we're going to stick with the path. Now, if they end up being intubated, so be it. That's a whole nother discussion, but we're just going to stick with phenobarb right now. All right. So we've decided we're going to use phenobarb. All right. We have our 2 pathways. All right, symptomatic and asymptomatic. All right. The beautiful thing about phenobarb in comparison to benzodiazepines is that I can use pharmacokinetics, big nerd word, in order to dose the patient appropriately to make sure that I take care of their alcohol withdrawal with a phenobarb weapon that I don't even really need to order because I can use kinetics. So before we get into this, one thing we want to remember is for every 1 milligram per kilogram of ideal body weight, and I'm going to underline this because this is very important. Do not use actual body weight, of ideal body weight of phenobarb. This should give you a phenobarb level of 1.5. Does anybody here know the normal level range of phenobarbital? Pharmacy people, can you help me out? Leave me hands. So it's anywhere from 14 to 40, so we'll call it 15 to 40, all right? Keep the numbers easy, all right? I know that for most patients with alcohol withdrawal, if I get them between a level of 20 to 40, their alcohol withdrawal should be controlled within reason, and they should not be at risk for seizures or DTs unless there's some other underlying cause of that risk, okay? So with this math, if I use 20 mgs per kg, that gives me a level of 30. All right, I'm right there in the middle, okay? So this is where we come into our approach of symptomatic versus asymptomatic. And certain attendings that you work with might do this a little bit different, but the principles are all the same, all right? So let's start with an asymptomatic patient. What I'm gonna do if they're asymptomatic is I'm gonna say, let's calculate this, right? We're gonna come up with our total, all right? So our total is 1,300 milligrams of phenobarbital, all right? I'm using this math because our vials for phenobarbital come in increments of 65 milligrams. So our orders are either going to be given as 130 milligrams or they're going to be given as 260, traditionally 130, right? So say our total dose for 20 mg per kg is 1,300 milligrams. Asymptomatic patient, I'm going to say, okay, Uday, let's go with 130 milligrams, Q, 30 minutes, PRN, and we're going to talk about that, PRN. So when we're going to phenobarbital, as some of you heard me say upstairs, discontinue the CWA protocol. CWA in this institution does not incorporate phenobarbital, therefore nursing should not be titrating their phenobarbital or giving their phenobarbital based off of a CWA score, all right?
Then in that case, are you using a RAS score?
Yes, exactly. So our ICU nurses, they're the most familiar with using the RAS score. Everybody here familiar with the RAS score?
Mm-hmm.
Richmond Agitation Sedation Score, right? So when you're normally sedating someone, you're usually targeting 0 to -2, right? To keep them nice and sedated. In this, we're going to be giving it if the RAS is greater than 1. That tells me that patient's agitated, tells the nurse the patient's agitated. Here's your phenobarb, okay? The one thing you want to remember about phenobarb is it does take longer than a benzo to have full effect. Some patients might not respond for 30 minutes to an hour, okay? So just keep that in the back of your mind. We're going to do this times however many doses gives us 1,300, so times 10 doses. At that point, we've reached our 20 mg per kg, This can be given over a 48-hour period, because as we mentioned, the half-life is 50 hours. It doesn't have to be within 24, 48, 70, it can be over a couple of days. Once they've reached this, we should have a level of about 30, okay? At this point in time, we should be reassessing our patient. Are they still exhibiting signs and symptoms of withdrawal? The answer to that question is yes. Do we think this is still alcohol withdrawal? That answer is yes. We can give an additional 10 mg per kg, okay? Which gives us 30 mg per kg total, which would give me a level of 45, okay? Slightly above our normal range. But I know from a pharmacy standpoint, you're not going to run into side effects of phenobarbital like coma, respiratory failure until your level approaches 60. So we have a big wiggle room. So with even out checking phenobarbital levels, I know I'm safe from a respiratory standpoint for these patients. All right. At this point in time, if you've reached 30 mg per kg of your total package and your patient is still having symptoms, really time to start asking ourselves, what else is causing this patient's symptoms? Are they having ICU delirium? Do they have opiate withdrawal? Do they have other forms of schizophrenia or other underlying psychiatric disorders? That's when you start adding your things like Precedex if they're still on PO, using antipsychotics if you have to, or Depakote, which I'm not going to get into right now. But that's when you start looking at those other things, right? This patient is now protected from those seizures and DTs. Putting someone on Precedex now, perfectly fine. All right? Asymptomatic. Symptomatic, we're going to do things a little bit different. We're going to take our 20 mg per kg, and based off who your attending is, 5 to 10 mg per kg of that will be given as a load right up front, right? If you had a patient that was actively seizing with status epilepticus using phenobarbital, you give 20 mg per kg, boom, right up front, right? So we're doing half to a quarter of that. So they're not going to go into respiratory failure. Usually they just take a nice long nap, all right? Load, and then the remaining 10 to 15 mg per kg, give as your 130 Q 30 minutes times your doses. And then the same process happens. Go through that cycle.
Is there any detriment to starting even for the asymptomatic patient? I mean, asymptomatic, meaning no seizures or DTs, but still more on severity of the symptoms by loading them with 10 to get a level of 15.
Once again, it's going to be your preference. It's going to be what you get comfortable doing with experiencing using phenobarbital. This is just how I approach it. As I mentioned, some attendings load everybody. Some attendings don't. So it's going to be what you become comfortable with and what you like and what you think works best for your patients. Sometimes we'll do certain regimens in specific patients that we're familiar with. They come in all the time. We know which ones like to be loaded, which ones don't like to be loaded, but it's going to become what you're comfortable with. The principle is just capping your dose and reassessing your patient appropriately.
So if the phenobarb 30 mics per kg cannot, don't have a risk of respiratory depression, why don't we give it on the floors? Like what's wrong with
that? Is unfortunately how do I put this? A nursing comfortability issue. They are not comfortable pushing IV phenobarbital on the floor. I don't know if that's just hospital culture.
There's probably a risk involved too, same way why.
Correct. I think the biggest issue for us, and this is the reason why we actually didn't go forward with a full-blown protocol for this, the concern is that if you're pushing it on the floor with, say, one attendant, and then the next attendant comes in and goes, I don't like phenobarbital, here's Suwap. And then when we start crossing groups, then they're definitely coming to me with a ventilator, right? Because they're going to be intubated. Correct. And that's the biggest concern.
Is it available only IV?
IV, IM, or PO.
Can
Right.
we give PO?
You can order PO and IM on the floor, but remember, it's not part of your CWAP protocol. So you'd be going off protocol, which most nurses are not going to be comfortable doing, and they're not going to be able to do a RAS score, right? Because they're not trained in that like an ICU nurse.
So I think that brings up a really good point is you have the very, very, very acutely agitated patient. You are very confident that this is due to alcohol withdrawal. But now there's going to be a delay, your classic delay overnight, which is getting the patient from a floor bed in 1 East or 2 East up to the ICU. What can you do right there and then to give phenobarbital? Because you don't want to give any more benzos. And so there's a few things that you can do is, patients are going to take PO meds right now. You can do IM phenobarbital and you can do the higher dose. Or if you are able to call your ICU nurse, have them bring over the IV phenobarbital, and then as long as they're and you are there, you can safely administer it. Now, because you want to, at least in my opinion, because you want to avoid any issues, I would recommend not just asking the floor nurse. Sometimes even like as an ICU nurse who is working on the floor to protect yourself, don't ask the floor nurse to give it without an ICU nurse there, because at least you're covering yourself. Because per hospital policy, we shouldn't be giving IV phenobarbital on the floor. But if you feel like you need to, either do the IM or bring an ICU nurse over with you.
Is IM absorption the same?
No, it's not gonna be quite as good. You might need a little bit of a higher dose and it's gonna be much slower to work. Yeah, IV is gonna be much more optimal.
And PO, I don't remember.
Same thing, they're all one-to-one conversions, but it's gonna take a lot longer to start working.
Would you adjust the doses or, because a lot of these patients are liver
Good
failure?
question, right? So patients with liver dysfunction, this drug is metabolized by the liver, right? So patients with liver dysfunction, you might not need quite as high of doses or as many doses, which is why it's probably better for those patients to leave it as the as needed versus the big load up front if you can, because at a certain point they will plateau and they won't need all of their doses. The other thing to remember is a lot of our patients who have alcohol withdrawal also have liver dysfunction, or sometimes patients who are alcoholics try to overdose on Tylenol, all right? If the patient has overdosed on Tylenol, they cannot receive phenobarbital for their alcohol withdrawal, okay? The reason being there's a toxic metabolite, right, that's formed from Tylenol overdoses, NAPK for short, right? So that is produced by the 2E1 pathway within the liver, all right? This drug induces that pathway, which means it hypermetabolizes Tylenol into its toxic form and will worsen acute liver failure in a Tylenol overdose. So if they have a Tylenol overdose, and they also have alcohol withdrawal, because that commonly does happen, do not use phenobarbital.
So is it protocol to get Tylenol level before ordering phenobarbital?
It's not an actual protocol, but most of your patients that are going to be coming in acute liver failure, you're probably getting a Tylenol level in the ER. You probably should in the ICU, but that should be definitely, if that's on your differential, no phenobarbital, give them benzos.
And if you don't know the NAPK pathway, why are you a doctor, right? You should absolutely know it. If you don't know the NAPK pathway, like, you should go back.
You just watch Critical Care Lounge. I talk about it for 15, 20 minutes.
What's that one?
Yeah.
All right, cool. Any questions on that? All right, so the next one, another common thing that all of you guys will be seeing is, especially for some reason in this area, because the population here loves their drugs, is that you have your patients who you put on the ventilator and you sedated them, and they're on 50 of propofol, 200 of fentanyl, and they're awake looking around sitting on them. What approaches would you recommend us taking to safely sedate this patient so that they're not a harm to themselves, so that you don't risk keeping them on 50 of propofol and 200 of fentanyl for days on end, at which point your chances of successfully extubating this patient a couple of days from now are going to go away?
Yeah, this one can get really difficult. We do have a lot of these patients. And this is where, as Uday mentioned earlier, that yes, 95% of the time we use evidence-based clinical, literature-based medicine. In this scenario, I'm going to talk a lot about my opinion and my experience in dealing with these types of patients, okay? So it's not going to be 100% something you can find in a textbook, all right? So our classic is going to be your opiate/heroin abuser, right? That comes in, who notoriously is going to be resistant to your normal sedatives, right? The most common one that we have the issue with is fentanyl, right? Our standard go-to is fentanyl. My resident and I were just talking about this downstairs. We love fentanyl, right? It's cheap, quick on, quick off. Most patients respond very well to it. It's hemodynamically stable. Unfortunately, it comes along with a side effect called tachyphylaxis. And patients who are opiate addicts develop tachyphylaxis much faster to fentanyl than your traditional patient. Does everybody know what tachyphylaxis is? We talked about it yesterday. Everybody know? If anybody doesn't know, please say you don't know so we can talk about it. Don't know, okay. So tachyphylaxis, just to keep it simple, is basically your receptors become used to a certain drug, and no matter how much you increase that drug, you don't respond to it anymore. So you need a different agent. And my theory or my hypothesis as to why patients who are used to heroin or street abuse drugs, specifically opiates, don't respond to fentanyl is because of its synthetic properties, right? Fentanyl synthetic, no histamine release, no high, none of that deal, okay? So the histamines are very responsible for those receptors reacting to opiates, right? So these patients notoriously be on 200 micrograms fentanyl right away, no response, agitated, trying to pull their tube out, okay? Heroin converts to morphine or a form of morphine in the body. They love morphine. Any other time, any other scenario, I hate morphine. I wish I didn't even have it on formulary here, okay? We won't even get into that right now. But a young 25, 26-year-old overdose who has good kidney function, who is, addicted to heroin, Morphine can work substantially well for decreasing their sedative requirements and their opioid requirements. If you're uncomfortable with morphine, Dilaudid works almost as well. Dilaudid drips will work much better than a fentanyl drip, okay? Sometimes they don't respond to propofol, in which case sometimes you need to use as needed benzodiazepines, which would be preferred over a drip, right? But sometimes these patients need burst infusions as well. Sometimes if they're intubated for an extended period of time, they're on these drips for an extended period of time, right? Even if we switch them to Dilaudid and we switch them to Versed, right? And we're having difficulty getting them off the ventilator, as they said, and this happens all the time. There are different approaches in which you can take, and we learned a lot about this actually during COVID. And the reason why we had to learn about a lot about this is because we ran out of drugs. The whole nation ran out of drugs. Like we were running out of propofol, running out of fentanyl. We had to come up with different ways to keep these patients sedated. So we developed different conversions for starting patients on standing oral opiates or standing oral benzodiazepines, right? So our standing oral opiates would be oxycodone or Dilaudid, and our standing benzodiazepine would be oxazepam or Valium diazepam, right? If they had liver dysfunction, they got oxazepam. And if they didn't, they got Valium, okay? The one thing I like to shock everybody is what the actual conversion is for these medications. Right, because every nurse is going to freak out when you do this. Just putting you on warning. How much oxycodone do you think is equivalent to 25 mics of fentanyl an hour?
A lot more than you think, because the what do you call it? Morphine equivalent conversion is high, but I don't remember what the numbers.
It's like 7 to 1 or something like that.
So you need 30 milligrams of oxycodone every 4 hours standing to just equal 25 mics of fentanyl.
30 Q4.
30 Q4 standing is 25 mics of fentanyl an hour. That is nothing, right? But you think it is a lot because it sounds like a lot for oxycodone, and most nurses were very uncomfortable with this. But that's your conversion. Now, once you start giving some of these drugs that have that histamine release, it doesn't exactly equate that way, and sometimes you can use lesser doses, but you might need higher doses. For the Valium, 10 milligrams Q6 gives you half a milligram of Versed an hour. That's it. We have patients on 8 milligrams of Versed an hour, right? So that's the thing to keep in mind. But the sooner you can start that, if they can use their gut, the quicker you can reduce the IV sedation and hopefully get them extubated. There's another method that I'm definitely not going to get into that Uday and I both like. It's called ketamine burst. And using ketamine to basically desensitize, resensitize the opiate receptors and reset them to basically get these patients off of the IV sedatives, both opiates and your GABAergic medications, within a 72-hour period.
Now, are you using a dissociative dose?
No.
Or, okay.
No. So that's the thing. And most of this literature has been used in oncology patients to try to get them off of their opiates. They've been doing it a lot in patients who are on ECMO for extended periods of time on IV sedation, which hasn't been written up in literature. Uday and I are kind of working on this, but unfortunately, ketamine's been on national backorder, so we haven't been able to do it that often. But it does work, but dissociative dosing is important because once you breach 360 milligrams a day total in a day of ketamine, you've reached the dissociative dose. So we would just run 10 milligrams an hour, which is like nothing, for up to 72 hours, and it's amazing how the opiates and the allergy and those sedatives just come right off. And don't ask me, they don't 100% know how it works.
And we've done this a few times. I think we have 2 pretty good cases here that we've done it on, where patients were for almost a week maxed out on hope and fen, and then on top of that, a lot of we went off the fentanyl into like standing opioids, started to have use additional benzos just to keep them comfortably sedated, and we said, you know, this is too much. So we did the burst ketamine protocol that we, kind of like developed at Cooper, utilized it, and within days, these patients are comfortable, not requiring excessive sedation, but in both of those cases, the hospital ran out of ketamine.
It would be great if you could case match those patients, at power. Anyway.
Yeah.
Because I would do this at my old shop with no, real strong literature and things, in part because we were running out of things. And, during COVID, it was very difficult to sedate some of these patients and then to liberate them. So
I think it's going to be helpful. And then the one thing I want to add as far as getting people off the ventilator, the excessive sedation, is what type of agitation package do you want to come up with using antipsychotics possibly, right? So obviously we'll make sure that QTC is fine before we do this. And this is where a lot of my opinion is going to come in. Because the literature says that no matter what antipsychotic you use, they all have the same outcomes. Well, they don't improve outcomes, but they make us feel better because the patient is more relaxed and comes off those sedatives and analgesics sooner. I prefer in my normal elderly patient that's been intubated for a little while for pneumonia, I use Seroquel. All right. You do want to remember that Seroquel is one of the only antipsychotics that can cause hypercardic respiratory failure. And our wonderful Dr. Gerber is the first doctor to publish that. All right. So that's something to keep in mind, and it doesn't matter what the dose is. It can be 25 daily versus 300 BID. Right? The other one that I like in patients that are addicted to opiates or any other agents is Thorazine, which is chlorpromazine, which to me is a much more sedating antipsychotic. And has in my opinion, once again, there's no literature to support this, is a much better drug for those patients in keeping them calm and from being agitated.
Over Zyprexa or.
And like I said, it's my
Very
personal,
commonly used here, yeah.
yeah, my personal preference, that's all. Literature doesn't.
It's just a matter of who brings it up first on rounds.
Yeah. Yeah, I like to avoid IM injections, like Geodon's IM and things like that, because in my opinion, IM injections is going to agitate that person more if they know what's going on. But we do have droperidol now, if that's something that you do like, it's IM that works within 3 minutes, just like something like ketamine, which we try to stay away from in someone who has dissociative
I'm
agitation.
familiar with droperidol. What's the, talking about the dosing is like.
It's usually 5 to 10 milligrams is a one-time IM dose. It can be given IV, but you can get an IM, which is nice that it gets absorbed within 3 minutes.
And the frequency,
You can repeat it multiple times.
And any preference on droperidol versus Haldol?
I don't personally have a preference. I think if I'm going to go IV, I usually will stick with Haldol if I have IV access. If I only have IM access and I need quick action, I'm going droperidol.
The joke around here is that EM loves droperidol, we'll stick with Haldol.
Yeah. I'm happy though ER can have the droperidol because before they used to give everybody ketamine, big doses of dissociated ketamine, and they'd come up delirious. So they can have all the droperidol they want.
So any questions about stating the difficult to sedate patient or weaning these patients off these excessive drips?
what are we on back order currently?
Oh my God, the list to tell me what I
It's
have is
ketamine.
probably smaller. Ketamine's still on national back order, so it's reserved currently for RSI kits
Okay.
and for pediatric conscious sedation. Unfortunately, trust me, once it's available, I'll let everybody know. I am not a fan of ketamine infusions for analgesia and sedation as far as titratable drips, but for bursts, I'm a huge fan of.
I think another thing we forgot to mention is just also not very relevant here, but, and I guess we'll get to it if we get to GI, but when you're trying to pick your drips, I know some people love First drips, but which patients do you absolutely avoid First in?
They should know, we just talked about it.
Overweight patients, obese patients, and patients with hepatic dysfunction.
Even like, 6 to 8 hours of just being on a First drip at a good dose, these patients are gonna be out for days.
Yep. We
Because
had a
of
patient a few weeks ago that we had to put on the Versed drip. Unfortunately, they were morbidly obese and had some liver dysfunction, but their triglycerides were 800. So we were stuck. And we had them on the Versed drip for 2 days. They didn't wake up after we turned it off for 5 days.
Cool, all right. So next one, you have your patient, you get a rat call on, they're in extremis, they look blue, their extremities are cold, you need to get them to the ICU. Nursing supervisor's like, I'm working on a bed. Patient needs pressors now. You need to resuscitate this patient now. And if you haven't heard of this, I mean, this is like your Batman, this is your toolkit, this is your utility belt. But you have to do it correctly. So who here has never used push dose pressors before? And so this can be a life-saving thing for your patient, provided you do it correctly. And so, assuming this room, no one has ever used it before, how would you have us approach being able to use push dose pressors?
So the first thing, obviously, it's going to be based off of how much your patient's crashing, right? So if they're just a little soft, or you're getting ready to intubate the patient, you have time and you want it at the bedside to be prepared for post-intubation hypotension, things like that. The first thing you're going to want to ask whoever is, do we have the pre-made ones in stock that are loaded in the Omnicels, right? Because we do get them compounded from a company, and they should be in every ICU and ER Omnicell, right? Sometimes one back order. So that's the first thing you want to ask. The answer is no, we don't have it. Some nurses are familiar with making it. Obviously, if I'm there, I can make it for you, but it's very, very simple to make, okay? You have your crash cart, right? That's there for, say, you're in an emergency situation. Each one of there's two different types of push dose pressors that we make. It's either push dose epi or push dose neo, right, phenylephrine, okay? So if your patient's bradying, you're reaching for the epi. If your patient is just hypotensive, the tachycardic, you're reaching for your phenylephrine, okay? In the crash carts, there are vials of each of these. And even if you don't have a vial of epi, you have this syringe, okay? All you have to do is grab one bag of 100 cc normal saline, okay? You push the 1 milligram of epi into that whole bag, okay? Draw it back out, and now you have a concentration of 10 mics per ml. So for every ml you push, you'll be getting 10 micrograms of epinephrine. For phenylephrine, you have a 10 milligram vial.
Wait, can you repeat that again, sorry?
Sure. So the vial is 1 milligram, okay, so 1,000 mics. Push that whole vial into a 100 cc bag of saline, okay? Now the drug's in the bag. Put your needle back into the bag and draw it out into a 10 cc syringe, right? Even the one that you just pushed it in with, draw it back out. Okay. Each ml now, since it's been diluted, is 10 micrograms per milliliter, right? Phenylephrine is a 10 milligram vial, so a 10,000 microgram vial. Same thing, push it right into the normal saline 100 cc bag, and when you draw that is 100 mics per ml. So you're pushing 100 mics per ml.
And then for norepi?
We don't do push dose norepi. I don't know of any actual literature ever doing push dose norepi. So that's something.
Oh, no, sorry. Norepi is carried in the Omnicell.
Oh, yeah, and it's in the crash carts, they can make drips. And the pharmacy, we have them pre-made. If you call them in an emergent situation, tell them where you're at, they'll tube it right to you.
What other pressors do we have access to quickly in a rapid situation?
Vasopressin is in the ICU Omnicells now. Obviously, that's not going to be a good one or rapid, but you should have access to Levo, Epi, and Neo all in your crash cart. You're not going to have enough Neo to make a drip, but you should have enough to make push dose until your drip arrives.
Okay. Any cardio iron trips?
We used to keep dopamine, which is one of the worst drugs ever created, which I'm not going to get into. We've removed that from the crash carts because it's no longer part of any real ACLS guidelines, and it really doesn't provide any benefit over epinephrine, and actually has higher mortality rate associated with it than Levophed or Epi.
No.
No, because they're not emergent.
Yeah, it's not a code, I guess. What I'm talking about is I can't get.
Availability, so availability-wise, both Bowden and Norna are pre-made, packaged in the pharmacy, so if you needed it relatively quickly, phone call, tell them where to tube it, and then put the order in afterwards.
So dopamine or Bowden?
Bowden and Norna.
Okay, yeah.
We have dopamine pre-made too, but if you order that, I'm gonna yell at it. My back phone's gonna be going off.
So there's no indication for dopamine.
That's right.
Yeah.
Where'd you sneak in from?
I'm always watching.
So the push dose epi that let's say we make it, is there, I know obviously you're using it as needed, but is there like a limit you should not cross, like 2 cc's per X amount of
There
time?
is no maximum dose for vasopressors or ionopressors. If your patient needs it, you give it to your patient. It's going to be at your clinical discretion and judgment.
Don't push one
Yes.
straight on a live patient.
Yeah. Correct. No, this is in emergency. Well, you can push the push dose epis and Neo in a live patient, right? Because it's a small dose, it's 10 mic. Not like you're pushing a whole milligram, but it's not the dead person dose. But, yeah, it's going to be your discretion. But you can always get more. Can't take it back.
What about the rates of the actual drip? So, I mean, I've used a dirty epi drip before and seen, that quote unquote, you push it in and then, what about the rates for those max dose?
There's no max. So every institution that you work at is required by law and regulations to have institutional maxes that are guardrailed on their pumps.
Gotcha.
Any physician, resident, fellow, it doesn't matter, has the ability and the authorization to override that. That's at your clinical discretion. And if you tell the nurse to run it faster, they need to run it faster, right? Because there are no maximum doses on pressors, or ionopressors or inotropes.
For you guys, are you all comfortable? Your patient is crashing in front of you and you see a delay. You called your rapid. And you should absolutely call the rapid for this patient if you think that you need a push dose pressor. But you asked for a crash cart. There's no Levophed available nearby. You need to resuscitate this patient now. You're getting your IV in. You've gotten your IV in. What are you instructing to your nurse to get this push dose epinephrine?
100 ml saline bag and one of the ampules of the epinephrine, the 1 milligram.
I mean, a liter.
No, 100 ml bag.
Gotcha.
Are those in the crash cart as well? The 100 ml
Yeah,
bags?
the 100 ml bags are in the crash carts, and both of the vials that you would need for those are in the crash cart. And also in the Omnicells.
I mean, I've seen one of the literature of using the 10 cc syringe.
Yeah, so what you mean the 10 cc epi syringe?
Yeah.
So it doesn't matter
Yeah,
which
like
one
the
you
10 cc,
use.
just a 10 cc flush.
You can do that so I don't do it that way. You require you to actually pull up less of what's in the vial. So for me, the easiest way to do it is with the 100 cc bag. That's why I make sure that I put the right amount into the dilution.
So you're basically injecting into the 100 ml bag, but you're only withdrawing the same amount, so the dosing comes out.
Correct.
I guess you just have to really make sure you mix that bag more.
It automatic, it's a straight dilution. So the second the water hits water, basically is what the two are. It instantly does it. If you want to shake it to feel better,
Yeah.
it's fine. Instantly, it will mix appropriately because it's not viscous.
Do you have one of those ampules here that I need to just?
I don't have one right now. I know in the.
So I mean, yeah, it's just, this is what it looks like.
Yeah. And you don't have to just use an ampule. Like say in the crash cart is the syringe that you push during the code. It's the same dose as the ampule. So you could use that syringe and push that 10 cc's right into a 100 cc bag. It's not going to be exact because now it's 1,000 mics in 110 cc's versus in 100, but it's close enough. Okay. It's within the margin of error. You're within a 10% window.
Right.
And then do you push that every 3 to 5 minutes?
You push, no, it's not like a code.
Oh.
You're going to push it as you feel clinically necessary for your patient until your drip arrives. Once the drip arrives, it doesn't provide any extra benefit than the drip does because you can run the drip at whatever rate you're giving this. It's just to buy you time. And if you make one, they expire in 1 hour. If you make it bedside. After that, you can throw it out and make another one because you made it dirty in an unsanitary environment.
Crash cart comes with those stickers too, so if you make a bag, I know sometimes you guys do in the ER, like write out what you exactly put in that bag, because otherwise they'll think it's a bag of saline if you're getting. Actually, I mean, you're gonna have these resuscitations even in the ICU, like next time, like if Firth is there, do it with him, like go through it with him and make that dose, even though we're gonna be able to get the pressures right away, get that practice in.
Yeah. I'll usually be making things before things happen because you rounded with me the people I like to be proactive. I don't want to have to be reacting to who they yelling at me. I need push to the, I already have it. There you go.
Yeah, probably be better that way because then we can actually like hands-on
See it.
feel how we're
Yeah,
doing.
because you guys really aren't trained in how to mix things. You know, it's usually varsity nursing. So it's actually a very easy process to use the syringe and do it, but
Yeah, we don't actually-
having some practice probably isn't a bad idea. But in most of these scenarios, you shouldn't be mixing it. You should just know how to mix it and instruct your nurse how to do so. Because I have seen nurses accidentally basically dilute an entire vial of the 10 milligrams of phenylephrine in just 10 cc's, which basically means you're giving 1,000
I've
milligrams.
seen that too.
And the patient's blood pressure goes to like 300.
Yeah.
So you just need to know how to make it and instruct them on what to
And after you see it happen, you don't trust anyone but yourself to do it. Cool, questions? So.
Yeah, I would definitely, can you guys hear me okay?
Yeah, we can hear you.
Oh, this is Lindsay Glaspie here. Yeah, so thanks for pointing out all of these these extra pearls, and it gives a lot of tools in the tool belt when you're particularly on the fly, particularly outside of the ICU setting. But definitely what it would highlight that this is fraught with errors in both the mixing and then the administration. We'll definitely get a lot of practice with this, but I'd also recommend instead of kind of memorizing multiple different ways to do this, I personally have my approach and I pick just one. So I only do push dose epi and I personally mix it every time myself. And I personally am administering it cc per cc because this is not something that the nurses should be expected to do or be expected to feel comfortable with. You can put them in a really uncomfortable spot, because this is not how they administer, vasoactives. So the way I think about it is I'm going to make it, I'm going to mix it, I'm going to label it, and I'm going to hold it. And it's that way, this is the exact concentration. And instead of having to remember multiple different ways, pick one way and you can pick whichever one works for you. But we'll find something that you can stand by instead of having to have to think about the concentrations during a time of emergency. You've done this multiple times when you had time to think about it, you've had time to prepare it, so that when you need to do it on the most stressful moments, you can do it without, endangering anyone or having the staff be put in a place where they feel uncomfortable with either what you're doing or what they're being asked to do.
And what I'll try to do is get some expired vials, because we always are expiring drugs. Some expired epi, some expired phenylephrines. We'll get together almost like, not a real sim lab, but so you guys can actually practice doing it.
Yeah, super important, yeah.
Cool.
Questions?
Does this happen pretty often? We have to do this?
Try not to, but it does happen. Yeah. I mean, when you have the fast patient in 1 East,
Yeah.
right? I mean, just even if you get the rapid, even if staff is there right away,
Yeah.
like at the best interest of the patient, it's just too much time to resuscitate the patient.
And so you might learn that you run into a lot of issues where post-intubation hypotension.
Yeah.
And you might just become accustomed to, I want my push dose phenylephrine here with me in case I need it for this situation. I know Dr. Bont does that a lot. So it's probably going to be tailored to what you're comfortable doing.
Okay.
But we don't do that here, right? We have Leofed already in the room, right?
Yeah, that's what I was confused on. If we do
Investigation.
that, then we don't need the,
Why do you say that with a lab? Do we not have it available, or you're just talking about?
Well, in that worst case scenario where you end up
Okay.
having, in that scenario where
I
you,
was like, is
where it does
Leland-
happen, where you're not able to get the patient to ICU in time, you have to
Yeah.
be on the floor.
I see, yeah.
You know, without your trusted staff there,
Yeah.
like, it's a risky patient, it's a risky intubation, you have to do it emergently, like everything bad that can happen,
Mhm.
you have to expect to happen. One of them is that the hemodynamic, they're going to become very unstable at action and you have to resuscitate.
Yeah.
But very intubation arrest, like, they're pretty general enough, it's during those cases. Kind of touched on this a little bit, so, you know, you have your cardiogenic shock patient, and so there's always that debate, milrinone versus dobutamine, milrinone versus dobutamine. Quickly, like, what's your viewpoints on that, what you know?
So I don't know how many of you were aware, but there was a newer study that came out just within the last couple of years. It was a very large, well-done study that compared milrinone versus dobutamine in cardiogenic shock, and it showed no difference, right? This is where it comes in that, okay, we have our evidence-based medicine, but what clinically and physiologically makes sense for that specific patient? So let's talk a little bit about the two by themselves. Let me switch to the. All right, so let's talk a little bit about dobutamine first. Don't worry, Mike, I didn't say dopamine, I almost did. All right, so dobutamine for the most part is primarily going to be working on beta 1. It does have some beta 2, but we're primarily targeting beta 1, right? So for these patients specifically with this medication, because you're stimulating beta, you're also not only going to have inotropic increase, you're going to have chronotropic increase, right? So patients for me that are actively having tachyarrhythmias or at risk for tachyarrhythmias, I might want to try to avoid dobutamine if I can. Now, that's not always the case, but I might want to try to avoid it in those patients, right? So, all right. The next thing is when you're thinking about physiology, right? And this is going to be my poor excuse of drawing, but let's pretend that this is your heart in 4 quadrants. This is your vena cava coming in, aorta coming out anyway. So cardiac output, preload, afterload, right? When you're stimulating beta, right, we're primarily targeting to increase cardiac output. As a feedback mechanism, you're going to have a decrease in afterload, right? So you have to be aware that there is a potential for hypotension, right? It can occur. It's not going to be extreme, but it can occur, right? So remember that it can cause hypotension. Don't worry, when we compare this to milrinone, we'll have that discussion, all right? The other thing with dobutamine that's nice is it's not renally adjusted. Okay. Also is in relative terms compared to milrinone, quick on and off. All right. The other thing you want to remember about dobutamine is the fact that because it works on beta, a lot of our patients also require rate control. All right. And a lot of those patients with heart failure require beta blockers. Now, obviously, in acute exacerbation, nobody should be on beta blockers. Right? But once you're managing the patient and they're becoming more stable, you might need to initiate a beta blocker. You probably don't want to put someone on a beta blocker who's on a beta agonist. All right. So that's kind of how I approach dobutamine. All right. For milrinone, this works a little different. It's a PDE3 inhibitor, right? Phosphodiesterase inhibitor, right? So what does that sound like to you drug-wise? What other drugs are phosphodiesterase inhibitors? Well, someone, I see him smiling over there. If an erection lasts longer than 4 hours, go to the ER, right? don't take nitrates for chest pain while you're on Viagra, right? So it's just like your erectile dysfunction meds, right? So because of that, it causes a lot of vasodilation in addition to having positive chronotropic effect, right? It's gonna have less inotropic effects. It's not working on beta cells. It's primarily gonna have chronotropic effect from cyclic AMP, right? So you're gonna have less concern with your tachyarrhythmias, all right? I can't spell today. Not as concerned. Not to say that they can't, but not going to be as concerned, right? Because it's a PDE3 inhibitor, it also works similar to our pulmonary vasodilators. So you can actually get pulmonary vasodilation. So this drug might be preferred in patients with right-sided heart failure in addition to their left-sided heart failure, okay? All right. The one thing you do want to remember, though, it is renally dosed. So patients with renal impairment, you're going to exponentially increase the half-life of this medication, and the half-life of this medication is already long in comparison with dobutamine. So basically, how do I approach it? Once again, the literature says there's no difference, but I look at these different caveats. Patients with tachyarrhythmias, I might want to try milrinone versus dobutamine. Patients who are at right-sided heart failure, I might want to try milrinone over dobutamine. Patients with renal dysfunction might want to use dobutamine. The other thing, what was I going to mention? Oh, that's right. So we talked about hypotension. So let me make sure I get that right. So in addition to increasing cardiac output, which decreases afterload, which causes hypotension with your milrinone, in and of itself, it causes vasodilation. So you're going to have more hypotension with milrinone than you would with dobutamine in your actual patient. All right. So the patient's already struggling with hypotension. If you can use dobutamine, go for it. Once again, it's a matter of balancing it based off of how your patient is presenting.
And how are you dosing the dobutamine? Like, is it just...
You usually don't titrate. It usually starts at like 2.5 or 5 mics per kilo per minute. And you're going to go, hopefully, based off of, if we have it in, a slung. You go based off of your output, your index, and all of your hemodynamic numbers. And if not, I know Fude doesn't like this, you can use the Fick equation, old school, or if you're very good at ultrasound, you can use your ultrasound skills as well to see if the patient is responding. And obviously, urine output is always good as well, too.
I think a big mistake we do is titrate all this to a map. Your goal here is not a map, right? In fact, the map might have been fine when you started this. You know, the patient maps could have been in the 80s, 90s when you started this. Your goal here is perfusion. Your goal here is cardiac output, and that's what you're titrating to.
Excuse me. Going back to the point you made about milrinone being renally dosed, is an AKI enough to cut that dose in half?
You can dose adjust it. Yes, you can. You just got to be, careful because, like you said, if something does happen and you turn it off, it's going to take time for that drug to wear off. Yeah, you mentioned different body systems.
Yeah.
Man. Speaking of cardiac ambulance. Pulmonary vasodilator.
Yeah, that's it. All right, so you see this patient. You brought this patient over the ICU. You guys probably saw a lot of these patients during COVID, right? And they have refractory hypoxia. You have them on peak of 14, 15, 100% FiO2. You've prone them, you've paralyzed them, but their SATs are not coming up. They're in overt ARDS, and now you're kind of reaching for everything in your handbook. And one of the things that we have in our toolkit is pulmonary vasodilators. What do we need to know about those? How do they actually work? And when it comes from a practical standpoint, how are we actually administering them, and why are respiratory therapists always so mad at us?
Yeah, so I mean, originally we used epoprostenol here, Velletri, Flolan, or the brand names. Respiratory therapy traditionally doesn't like it because it requires very close monitoring. They have to go in and see the patient every hour to possibly adjust the infusion. But for the most part, for our pulmonary vasodilators, when we're talking about ARDS, and I might get some pushback from my pulmonologist that's on the call right here, but the literature using epoprostenol or pulmonary vasodilators is primarily for pulmonary hypertension, and that's where it actually primarily should be used. During COVID, obviously, we were dealing, as Uday said, with a lot of refractory hypoxemia and struggling to oxygenate these patients. Studies have been done even before COVID looking at these pulmonary vasodilators in ARDS and has shown no mortality benefit in these patients. What it basically does is it kind of buys us some time to bridge to hopefully an alternative therapy, right? So your patient's hypoxic, say you've gotten off the phone with Dr. Glassby, who's over at Cooper on ECMO call, and she's accepted the patient for ECMO. You already have, this patient who's extremely refractory, and you just can't oxygenate him. You really need to get them there, right? Because they don't come here with a team. We got to get them there. Epoprostenol might be a good idea to give these patients to help increase oxygenation, to buy that patient time to get to Cooper so Dr. Glassby can throw in the cannulas in order to get this patient hooked up to circuit, right? Another time we used it was when patients had to be prone, right? And we're too hypoxemic to be prone. We were afraid they were going to code. Give them some Floam, get the oxygenation up, prone them. It's not a long-term solution because basically what this medication is doing is through its pulmonary vasodilation is going to cause blood flow to areas of the lung that potentially is no longer functioning or participating in gas exchange, right? We saw notoriously in COVID, these patients had fibrotic lung that was basically like concrete, right? It basically had no function, right? So we would initially see this nice spike in oxygenation. The patients would do better for a little bit. All of a sudden, that would plateau, phase off, and you would notice that their PCO2 began to rise, right? Because that dead space no longer can participate to remove the PCO2, all right? So it's not a be-all, end-all. We use it primarily as a bridge to other therapies, or as what we like to call a salvage therapy. There's no literature to support its use for a mortality benefit.
And so what
The only other thing, I agree with you first. The only other thing I would add is that one of the problems that you have when you're using either nitric oxide or inhaled epoprostenol is you're actually running the risk of confounding other therapies. So for instance, we know there's a mortality benefit with proning patients when their PDEF ratio is less than 150. We think that there is a mortality benefit with ECMO for patients with a PDEF ratio less than 80, depending on the circumstances. So if you put someone on one of these inhaled vasodilators that doesn't improve mortality, you may raise that PDEF ratio, taking them out of the window for those other therapeutics that we know do improve mortality. Does that make sense?
That's an excellent point. Excellent point.
Seem to put a false band-aid on it that kind of takes them out of the criteria for that ECMO therapy, I see. But I guess you're saying if you have refractory hypoxemia with signs of pulmonary hypertension, so that would be looking at the right heart, looking for right heart strain. Mm-hmm. Would this also be indicated maybe in like a massive PE, for example? If you have nothing, obviously you have. Like,
I'm not familiar with it, and you guys jump in, please, to help me. I'm not familiar with it being used for pulmonary embolism, only because really the only way to effectively fix that right heart strain is to remove
the embolism, yeah.
It's primarily more just in pulmonary hypertension for the most part. I mean, if they have right heart strain for other reasons, you can give it a shot, but
and it's only for the, I'm sorry, it's only for the acute pulmonary hypertension. I mean, you can also use it for the chronic of people who are chronically
waiting for transplant, sitting on epoprostenol in a transplant center for an extended period of time.
Okay.
So, no, sorry, I was waiting for the light.
I mean, Dr. Bob, correct me if I'm wrong. I mean, even with, pulmonary hypertension patients who are like in the severe stages, pulmonary vasodilators, the evidence is all for type 1, but lately I believe there's some good evidence for your CTEPH patients coming out. I haven't looked at it in a while, but I think there is some emerging evidence for it. I don't know if it's indicated in the acute stage. I think these are more for like your CTEPH patients.
Okay.
So I think it's tough because the one thing you're trying to avoid is the compensatory vasoconstriction and then subsequent vasodilation to the areas that are participating in gas exchange. The only medication that I know that has good evidence for it in group 4 pulmonary hypertension is riociguat. And like you were saying, all the other ones, really the best evidence is for group 1 because you can actually make the other disease processes worse. Yeah, so that's definitely something I would be worried about. But actually, Dr. Hussain is here, and she might be coming by in a little bit. She's actually part of the PERT team at Cooper, so she might be able to answer these questions a little bit better.
And we do epoprostenol here just inhaled. We do not do IV epoprostenol. That was where you run into a lot of hemodynamic side effects, hypotension.
Cool. Well, we'll leave that last one. Firth, thank you so much. Appreciate it, man.
Anytime.
You guys have any questions before you guys on?
Good?
Yeah.
All right, guys. Thank you, man.
I saw somebody asking blue question. Pretty sad with the movie.
Don't worry, we'll have plenty of time to talk about math.
All right, cool.
Love math.
Why don't you guys take like a 5-minute break and I'll set up for the next lecture. We'll be going over, it's a recording of